Good afternoon, ladies and gentlemen, and welcome back. Let us resume our conference with a vital and timely topic: antimicrobial stewardship at the rising phase of antimicrobial resistance. The chairpersons for the session will be Dr. Malika Karunaratne, consultant microbiologist at the National Institute of Infectious Diseases, past president of Sri Lanka College of Microbiologists, and Dr. Chamila Dalpadadu, consultant physician and senior lecturer of Department of Physiology, Faculty of Medicine, University of Colombo. Dr. Karunaratne and Dr. Dalpadadu, it's a pleasure to have you with us today.
Thank you very much for the kind introduction. Good afternoon, everybody. Now, we have gathered here for this plenary, after lunch plenary. Actually, it's a very important topic. Antimicrobial stewardship in the rising phase of AMR. I think it's very important for our country, this topic, because now as a country we have started antimicrobial stewardship program, systematic implementation of antimicrobial stewardship, and from the Ministry of Health also, they have issued national guidelines. We have started so many programs nationally and locally. So I think this is a very timely topic. Let me introduce today's speaker, Professor George M. Varghese. I think he doesn't need any introduction to this forum anymore, but however, now I will introduce him. In the ever-evolving field of infectious diseases, several distinguished professionals have made significant contributions to clinical research, education, and global health initiatives. Among them, Professor George M. Varghese from India stands out as a leading figure, currently serving as the professor and head of the Department of Infectious Diseases at Christian Medical College, Vellore. He brings a wealth of expertise and qualifications, including MD, DNB, DTMH, FRCP, and FIDSA. His notable positions include President of the Clinical Infectious Diseases Society India, President-elect of the Royal Society of Tropical Medicine and Hygiene, Scientific Advisory Committee member for the Indian Council of Medical Research, and Council member of the International Society for Infectious Diseases, reflecting his profound influence on the global stage. Podium is yours, sir.
Thank you, madam, for those kind words of introduction. The first challenge is to keep you awake after a good lunch. And of course, the second challenge at the end of this talk is to convince you how important antimicrobial resistance and the antimicrobial stewardship to tackle the antimicrobial resistance is and take action towards that. I remember about 2 years ago, in 2023, I spoke in the same forum, the first the infectious disease conference, and at that time, Dr. Nilanka and Dr. Vimalasiri and colleagues organized a fantastic conference, and although I attended it online, last year they were there in Hyderabad in India for our national conference, and while talking to them, I realized they were dead serious. They were committed to take this infectious disease forum forwards with the support of the Ceylon College of Physicians. With so many youngsters here, I thought it is important to mention a couple of things, and rightly why Dr. Nilanka and Dr. Vimlasari and colleagues are so enthusiastic about this is when you see the infectious diseases as a specialty in several countries where it's well established, you will realize there is a structured program, and for the youngsters, you will know this is a specialty which cuts across all organs and systems, and therefore it's very intellectually challenging. You saw that through the cases, and also it's rewarding because almost all the infections are treatable or curable. Now, the other important area which you will be faced with is actually the antimicrobial stewardship. And I thank the organizers for providing me this opportunity to talk to you about antimicrobial stewardship, which is not only important for me personally, but also it's important for every one of us, every clinician, every hospital, and every patient whom we care for. Antimicrobial resistance is challenging not only for infectious disease physicians, but for all of us. This is something which will impact the way we treat common infections. You saw that through the cases in the morning. And also, if we have to protect the gains we had with modern medicine, we have to do something about it now. Now, I will be talking about three aspects about this issue. Why should we worry about antimicrobial stewardship? And you will realize the stakes are high, and I will talk about it. Why is it important? And of course, when we say antimicrobial stewardship, what do we mean by that? And what are its goals, core strategies, activities, and the multidisciplinary team which drives the whole program? And then finally, the real world implementation, very similar to your situation in a developing country like India. How do we tackle the problem? Some practical tips for implementation of the program. Many of you may have seen this data which was published in Lancet last year. This shows that there were about 4.7 million deaths associated with AMR and 1.4 million deaths directly attributable to AMR in 2021. This, you will remember that this is during COVID, and this data clearly tells you that there is significant inequalities across regions. You can see the red regions in different parts of the world. And mind you, during 2020 and 2021, there was notable decrease in non-COVID related infectious diseases. Of course, the COVID drove a lot of mortality, and even with that, you see the burden of antimicrobial resistance. Very similar data, a little more. This is 2019, close to 5 million deaths associated with AMR and 1.27 million deaths directly attributable to AMR in 2019. And there is data which, the projected data shows that there will be 10 million antimicrobial resistance associated deaths by 2050, surpassing both cancer and road traffic accidents put together. So this is truly a silent pandemic. You know that the COVID-related deaths were about 6 million in 2 years. So you can imagine this silent pandemic causing the millions of deaths across the world every year. And that's the importance. The antimicrobial resistance, we know, is driven mainly by the antibiotic consumption, be it appropriate or inappropriate use. And there is significant disparity between countries in terms of antibiotic use. And when people looked at the patients attending primary care facilities in low and middle income countries, more than 50% of patients receive at least one antibiotic prescription, and most of which are not needed. But the question is, why do we, as physicians, overprescribe antibiotics? Unless we know the reason, how do you tackle that? There are three primary reasons, and this is well evidenced. The first one, of course, is we are all physicians. We want the best things for our patients, and we don't want our patients to have a bad complication, particularly in uncertain clinical presentations. And also, prescribe antibiotics just in case if it's a bacterial infection. Why? I should not be missing the. So that fear is what drives primarily the antibiotic prescriptions, which we need to address that fear, both for ourselves initially, and also once you're convinced, our colleagues. And in the morning, Dr. O.C. Abraham very clearly described to you, what are the thoughts which should go through your mind when you prescribe an antibiotic. And then, of course, the pressure from patients to prescribe an antibiotic. In majority of situations, you will face that. And insecurity in clinical decision making, where you have several patients, and therefore you have very limited time, and your diagnostic facilities are not optimal. You don't have a good point of care diagnostics to make an appropriate diagnosis. Therefore, that becomes a challenge. And many of these, unless you think about it and try to address that, you may not be able to successfully tackle the issues of antimicrobial resistance. Now, the way to combat antimicrobial resistance, it has to be a multi-pronged strategy. Both infection control and prevention, along with antimicrobial stewardship, forms important components of tackling the antimicrobial resistance. Then, of course, having antimicrobial surveillance as well as multi-drug resistant organism surveillance is another key aspect which you would try to implement in your own hospital. And of course, new drug development, which you may or may not be part of, maybe some basic science studies, or even clinical trials, and you may be part of it. But the infection prevention and control and also antimicrobial stewardship should be everybody's business. All of us should be convinced about it and should act on it. So when we say antimicrobial stewardship, essentially what we mean is a coordinated set of interventions designed to promote the appropriate use of antimicrobials, improve patient outcomes, reduce microbial resistance, and decrease the spread of infections caused by multi-drug resistant organisms. So essentially, there are three goals of this program. First of all, optimizing the antibiotic use, which actually should start with every one of us. The appropriate selection of the antibiotic, Dr. O.C. went through that very systematically, right from making a diagnosis to thinking about the organisms which is causing that particular syndrome, and prescribing the right dose, right route and duration. And secondly, improving the patient outcomes and minimizing the adverse effects. And third, reducing the emergence of resistance and hospital costs. Now, earlier there were questions about, when you use antimicrobial stewardship program, there is some amount of autonomy which is restricted, and also when you de-escalate all these situations, does it reduce the or make the clinical outcomes worse? The evidence is to the contrary. If you have a good antibiotic management program or an antimicrobial stewardship program, your patient outcomes are better. What are the core strategies when we say antimicrobial stewardship? You must think of these two core strategies. It's called front-end approach and the back-end approach. When we say back-end approach, it's prospective audit with intervention and feedback. It means that in your hospital, you choose certain antibiotics and you review every prescription and provide a feedback. So this is kind of, you're looking at clinicians prescribe as they practice, but there is a feedback which goes to the clinician. Was it appropriate? Can it be done better for the same infection? Can you give a better choice in terms of narrower spectrum? Maybe better choice in terms of penetration into certain tissue compartments, for example, CNS. There are many of those are considered and provided the feedback. So if you have a team, particularly an infectious disease team, or physicians who are interested in infectious disease, the consultations is one strategy where you would actually start with the feedback. In the hospital, you can decide certain antibiotics. Let's say, I'll come back to some of those lists. You will have to make the list of antibiotics which needs to be audited and provided the feedback. and then also looking at the de-escalation after the culture and susceptibility reports are available, etc. The front-end approach, on the other hand, is a restrictive strategy, where this requires an approval before prescribing certain antibiotics. Let's say you want to prescribe ceftazidime, avibactam, you want to prescribe a polymyxin, all that, it has to be authorized by either an ID physician or a physician who is trained in this, or a pharmacist who, with the physician's help, implements that program. So normally what happens is, the clinician, suppose if you have a sick patient who comes in with septic shock, and you think that there is a possibility of carbapenem resistance, or like the case which you saw in the morning, the clinician prescribes carbapenems, and then you look at within 48 hours, you look at the culture, the blood culture grows an organism which is ESBL resistant, and the person who approves the antibiotic approves to continue meropenem, or if the culture is negative, or if it's a susceptible E. coli, you may de-escalate at that point. So the initial prescription in a sick patient, they are allowed to prescribe, say, for 24 hours or 48 hours. Within that time, one would, look at the cultures and then whether to continue or not to continue. The intention is not to take away the autonomy, but to preserve certain antibiotics as long as possible. And the initial orders are funneled through these experts. It is much more, it is labor intensive, and use of antibiotic timeouts and formulary control is part of this strategy. The antimicrobial stewardship also has additional supplemental strategies, such as educating your residents, other colleagues, coming up with clinical guidelines, antibiotic guidelines and clinical pathways, streamlining or de-escalating therapy, dose optimization, parental to oral conversion, and computer-assisted decision support system. And many of those people have looked at the evidence, and you can see the strength of evidence and the how strong the intervention improves the outcome and reduce the antibiotic use. So when we look at the core activities, the first important activity is formulating antibiotic guideline for the hospital for appropriate antibiotic use. For every empiric therapy based on the infection, the guideline would say what should be the first choice and what should be the alternative. This is actually based on cumulative antibiogram of the hospital. You look at the previous 1 year's data, formulate the antibiogram, and then come up with, based on the susceptibility profile, you come up with the antibiotic guidelines. There should be audit and feedback on prescribing practices, surveillance of antibiotic use and resistance patterns. All these are core activities of the AMS, and the education and training of the prescribers. formulary restriction, as I said, and pre-authorization of select antibiotics. Monitoring and reporting. When we say antibiotic consumption data, either you can say, there are standard measures like daily antibiotic dose, which is kind of a, it's called daily defined dose. For example, if ceftriaxone for a day, the dose is 2 grams, and the hospital consumes 200 grams of ceftriaxone in a particular hospital, the daily defined dose DDD for that month will be 200 divided by 2 will be 100. So that will be the common measure. The other way is days on therapy. So this is essentially giving you the consumption of antibiotics. You can see the trend and decide which are the antibiotics which are which needs to have more attention, which are prescribed more commonly, and also looking at the clinical outcomes and resistance trends. Who should be in the AMS team? Usually a physician, if you have an ID physician who will lead or chair the team. If there is no ID physician, a physician who is interested in AMS, along with a clinical pharmacist with training in ID or AMS, who will look at the drug optimization and the strategies, a microbiologist who will look at the resistance trends and diagnosis, infection control practitioner who will concentrate on the infection prevention and coordination of the activities, an IT support or a data analyst for antimicrobial use and resistance tracking. Importantly, there should be a hospital administrator. There should be a buy-in from the policymakers or the administrators for the policy support and sustainability. Many of you may be aware of the AWARE classification of antibiotics, which WHO has come up with. The first-line drugs which are commonly used, which should be widely available, and the resistance potential is lower. Drugs such as amoxicillin, doxycycline, cefazolin. The watch group, which has higher resistance potential, ciprofloxacin, ceftriaxone, azithromycin are some of the examples. And reserve group, which is the last resort antibiotic for MDR infections, highly restricted and monitored, like colistin, linezolid, ceftazidime, avibactam. So you can choose based on the resistance pattern and the antibiotics. You can choose. Usually these reserve group are the ones which you start with when you're starting to implement the program. And also there are bacterial priority pathogens based on the resistance. Enterobacterales, which are carbapenem resistant, Enterobacterales, which are third generation cephalosporin resistant, or the ESBL producers, Acinetobacter, which is carbapenem resistant. Those are the critical group. So you would choose the resistance which you will monitor. Then there are system-wide interventions one would do. The antibiotic guidelines which you make should be easily accessible and available. Electronic prescribing and audit tools, clinical decision support systems, all these are system-wide interventions one may implement based on the resources and the practicality in every system. I'll come to that in a Minute. Now, the The directed therapy, we talked a lot about, defining the infection in three ways: anatomically, pathophysiologically, and microbiologically. What is the syndrome which is causing the disease? Say, for example, is it septicemia, endocarditis, pyelonephritis, or a community-acquired pneumonia? And then you think of the potential pathogens which cause that particular syndrome, and also consider the patient's condition. Is the patient seriously ill in septic shock versus somebody who is quite stable? When you just take few more minutes. And so the initial step, like it was discussed in the morning, is to make a clinical diagnosis, identify the syndrome, and you would also consider the factors such as, am I dealing with a colonizer or a true infection? UTI, you went through that carefully. Is it bacterial infection, or am I dealing with viral infection in syndromes like upper respiratory infection? Is it a community-acquired infection or a nosocomial infection? These are several components which you will think about in making your diagnosis. And also whether the patient is seriously ill, such as sepsis or septic shock, febrile neutropenia, bacterial meningitis. All those situations are the ones where you would start on broader therapy, with an empiric coverage, and then you target the therapy once the cultures are available. Most of the upper respiratory infections are viral, where you do not prescribe an antibiotic. Once the culture and susceptibility reports are back, you will narrow it down. People call it de-escalation or targeted therapy. Either narrow down the spectrum specifically to that pathogen, or convert from IV to oral, etc. And these strategies are clearly shown to have lower mortality compared to you continue on the same broader therapy. Some of the practical tips: when we started off several years ago, we came up with this antibiotic guideline in a booklet form. This was prepared based on the antibiogram. So you look at the cumulative antibiogram, something like this, where one look at it, the clinician will also know, the red ones are quite resistant ones, green ones are good ones, and you come up with antibiotic therapy. When you're looking at the antibiogram, initially you would look at the say blood culture isolates alone, which will actually give you that most of the isolates are true infections. Then you will make sure that you engage the clinicians all throughout in various specialties, and if you're able to come up with sustainable solutions through an EMR prescribing format, it makes things easier to implement. So to summarize, AMR is a silent growing pandemic. It's already causing millions of deaths globally. It threatens the foundation of modern medicine. The antimicrobial stewardship is not optional, it is essential. It protects patients, preserves antibiotic efficacy, and reduces resistance. AMS is a team effort, and you start small and think big. Harvest the low-hanging fruits first, and you start with smaller steps, but slowly progress. Sustainable AMS must be embedded into routine care. Therefore, education, monitoring, accountability are key. It is not about restricting antibiotic. It is about responsible prescribing or responsible use. The final thought is we may not have many new antibiotic in the pipeline, but we can make the existing ones last longer if we act together and act now. And lastly, the Clinical Infectious Diseases Society's annual conference this year is going to be in Mumbai from 11th to 14th of September. So it's my pleasure to invite all of you. I know that there is conflict with the CCP's annual meeting. So therefore, if you're not able to attend this time, maybe next year, it will be a good event where you can learn a lot of ID related topics, and there is a good discussion across. Thank you very much for your patient listening and the opportunity.
Thank you very much, Professor Vagesh, for that excellent presentation and sharing your expertise on this subject. As this is a plenary, there's no question and answer session, but I'm sure he's available throughout the conference to clarify any doubts. Thank you once again.